Good morning, everyone. So, today's topic is clinical diagnosis. Let's start. Proper diagnosis is essential for intelligent treatment. Periodontal diagnosis includes first determine whether the disease is present, identify its type, extent and distribution, severity, understand the underlying pathologic process and its cause. Diagnosis. What is diagnosis? Identification of a condition, disease, disorder, or problem by systematic analysis of the background or history, examination of the signs or symptoms, evaluation of the research or test results, and investigation of the assumed or probable causes. So now what is provisional diagnosis? The estimated identification of the disease underlying a patient's complaints based merely on signs, symptoms, and medical history of the patient rather than on laboratory examination or medical imaging. Interest should be in the patient who has the disease and not just the disease itself. General evaluation of the patient is very important. Now, what is case history? Case history can be defined as a systematic collection of data from the patient regarding his or her personal, medical, family, or any other data which helps in case analysis, diagnosis, and treatment. Now, what is the importance of case history? It is the first and foremost important steps. It leads to the correct diagnosis, which eventually leads to correct treatment plan. Proper clinical and radiographically examination is must. Now, case history includes age, sex, address, occupation, chief complaint, history of present illness, past dental history, past medical history, family history, personal history. Personal history includes diet, adverse habits, oral hygiene practices. Now, each and everything has its own importance, and we have to record everything for record and documentation purpose. Now, what is the significance of age? Like in perio, aggressive periodontitis, it is common in young people, and while chronic periodontitis is mostly present in elderly people. Wasting diseases like atresia and abrasion are common in old age. So now we come to chief complaint. Chief complaint should always be in patient's own word. This is very important. Chief complaint should always be in patient's own word. Chronological order should be followed and it should be as descriptive as possible. History of present illness. This is also one of the very important aspect of case history. History of present illness includes onset. That is, when did it start? When did the patient started suffering from the particular problem? Location, duration, character, aggravating factors, relieving factors, time and severity. So look for location, either the thing is generalized or localized. Duration, for how long? Character, character is mostly related to the pain, whether the pain is dull or sharp. Aggravating factors, factors which aggravate the pain, which increase the pain. Relieving factors, factors which decrease the pain, which relieve the patient from the pain. Timing and severity. For how long does it last? For example, perio pain usually stays for a variable duration without any stimulus and is usually dull in nature. Personal history is also very important, which includes diet, adverse habits, oral hygiene practices, Past dental history includes all the previous dental procedures which the patient has underwent. Past medical history, this includes all the medications on which the patient is currently on. General examination. It includes local examination, extraoral examination, face, TMJ, lymph nodes, intraoral examination, soft tissue, lips, buccal mucosa, palate, floor of the mouth, tongue. Gingival examination, periodontal examination. Now, gingival examination. Color changes in the gingiva. Change in the color of the gingiva is an important clinical sign of gingival disease. Normal color is coral pink and is due to tissue vascularity, thickness of the epithelium, degree of keratinization, presence of pigments. Now, this is the particular coral pink color of the gingiva. This is healthy state. Now, diseased state, color of the gingiva can vary from red, pale, and or in chronic inflammation, it can be bluish also. If the color is red, it is due to increase in vascularity or degree of keratinization is reduced or decreased. Pale, vascularity is decreased and epithelial keratinization has increased. In chronic inflammation, red or bluish red color is normally seen. This image shows diseased condition of the gingiva. Same as for this picture also. This picture shows particularly pale color of the gingiva. Now, the color changes may be marginal, diffuse, or patch-like depending on the underlying condition. For example, in ANUG, that is acute necrotizing ulcerative gingivitis, the involvement is marginal. In herpetic gingivostomatitis, it is diffuse. In acute reactions or chemical burns, it is patch-like. This is the diseased condition. This is also the example of diseased condition. This image shows patch-like thing. Color changes associated with systemic factors, that are systemic disease associated color changes of the gingiva. Many diseases can cause color changes in gingiva. Endogenous oral pigmentations can be caused by melanin, bilirubin, or iron. Melanin oral pigmentations can be normal physiologic pigmentations and are often found in highly pigmented ethnic groups. This shows the melanin pigmentation of the gingiva. Diseases that increase melanin pigmentation include Addison's disease and Albright's syndrome. Addison's disease, caused by adrenal dysfunction, produces isolated patches of discoloration from bluish black to brown. Albright's syndrome, it is polyosteotic fibrous dysplasia, and Van Rankelinghen's diseases produces areas of pigmentation. This is the example of melanin pigmentation due to systemic factors or systemic conditions. Skin and mucous membrane can also be stained by bile juices. Jaundice is the best detected by examination of the sclera, but oral mucosa may also acquire yellowish color. Deposition of iron in hemochromatosis may produce blue-gray pigmentation of the mucosa. Apart from these, certain endocrinal and metabolic disturbances like diabetes, pregnancy may result in color changes. Blood dyscrasis like anemia, polycythemia, and leukemia also induces color changes. Exogenous factors capable of producing color changes include atmospheric irritants such as coal, metal dust, and coloring agents in food or lozenges. Tobacco also induces hyperkeratinization of the gingiva and may have a significant increase in melanin pigmentation of the oral mucosa. Now, changes in the size of the gingiva. Normal size depends on the sum total of the bulk of the cellular and intercellular elements and their vascular supply. In disease, the size is either increased or enlarged. The factors responsible for this are increase in fibers and decrease in cells as a non-inflammatory type, whereas in inflammatory type, there will be increase in cells and decrease in fibers. So this is the normal, this picture shows the normal healthy condition of the gingiva, while this shows the enlarged size of the gingiva. Now, changes in the contour of the gingiva. Shape. The shape of the interdental gingiva is governed by the contour of the proximal tooth surfaces and the location and shape of the gingival embrasures. In health, it is triangular interdental papilla in anteriors and tent or flattened shape in posteriors. In gingivitis, which is a diseased state, it is either rounded or blunt interdental papilla. Now, in this picture, as we can see, it completely fills the space between the teeth and it does not bleed when being touched. The color of the gum is pale pink, that is oral pink, and there is no plaque on the teeth. This shows the healthy condition of the gingiva. Now, this shows the diseased state of the gingiva. Contour. The marginal gingiva is scalloped and knife-edged. The contour depends on the shape of the teeth and their alignment in the arch. The location of the facial and lingual gingival embrasures. Gingivitis, which is a diseased state, has rolled marginal gingiva. Okay. Now, this shows the normal healthy condition of the gingiva, while this shows the rolled out marginal gingiva, as we have discussed earlier. Now, changes in the surface texture of the gingiva. Normal gingiva appears to be stippled, that is, orange peel appearance, due to attachment of the gingival fibers to the underlying bone. Microscopically, alternate rounded protuberance and depression in the gingival layer may give to be a stippled appearance. Stippling is absent in disease condition, hence the gingiva may appear smooth and shiny. So in diseased conditions, stippling, that is orange peel-like appearance, is absent and it shows smooth and shiny appearance. So this is, here we can easily see orange peel-like appearance, stippling is present. Now, changes in consistency of the gingiva. Normal gingiva exhibits a firm and resilient consistency. Factors responsible are cellular and fluid content and collagenous nature of the lamina propria. Soft and edematous in inflammation, or it can be firm and leathery. So while in inflammation, it can be either soft and edematous or firm and leathery, while healthy state depicts firm and resilient consistency. So we can see the healthy, we can easily compare healthy state of gingiva and diseased state of gingiva. Gingival bleeding on probing. Two early signs of gingival inflammation. Increased gingival clavicular fluid production rate, that is increased GCF rate. Bleeding from gingival sulcus on gentle probing. These are the two very early signs of gingival inflammation. Now, gingival bleeding varies in severity, duration, and ease of provocation. So, early diagnosis helps in prevention of lesion advancing to periodontitis. Appears much earlier than the color changes or other visual changes of inflammation. Also, it is a subjective sign. So, gingival bleeding, bleeding on probing, is an subjective sign. How does it happen? How does the bleeding on probing occurs? So, dilation of the capillaries and engorgement of the capillaries leads to, it brings them closer to the surface. Now, due to the thinning of the capillaries, there are certain micro ulcerations in circular epithelium, which makes it weak, which makes the circular epithelium weak and less protective. So, on a very minor or major stimuli, bleeding occurs. So, this is the pathophysiology of bleeding on probing. The most common cause of abnormal bleeding on probing is chronic inflammation. The bleeding is chronic, recurrent, and is provoked by mechanical trauma from toothbrushing, toothpicks, food impaction, and biting onto solid foods. Now, gingival bleeding associated with systemic factors. In some systemic diseases, gingival hemorrhage occurs spontaneously or after irritation and is excessive and difficult to control. These conditions usually have a hemostatic mechanism failure. Now, hemorrhagic disorders in which abnormal gingival bleeding is encountered are vascular abnormalities, that is vitamin C deficiency or allergy, platelet disorders, thrombocytopenic purpura or vitamin D deficiency, coagulation factors, coagulation defects like hemophilia or leukemia, hormonal replacement therapy, oral contraceptives, pregnancy, and menstrual cycle also affects gingival bleeding. This point is very important. Oral contraceptives, pregnancy, and menstrual cycle affects gingival bleeding. Anticoagulants, antihypertensives like calcium channel blockers, immunosuppressive drugs also causes gingival bleeding. Bleeding on probing, stippling, and inference. So, if bleeding on probing is present, stippling will be present because it is a diseased condition. And we can see soft and edematous gingiva. If bleeding on probing is present, then stippling would surely be present because this contributes to an healthy state. And the gingiva would have a firm and resilient consistency. But if the bleeding on probing is questionable, stippling will be present and this will be also not normal condition, but it would be firm and leathery consistency of the gingiva. Now, changes in the position of the gingiva. Usually, the crest of the marginal gin is 0.5 to 1 mm coronal to the CEJ. CEJ is cemento-enamel junction. But in disease, the position can be shifted either coronally to CEJ or apically to CEJ. If it has shifted coronally to CEJ, it would be pseudo pocket. And if the position has shifted apical to CEJ, then it would be recession. Gingival recession. Exposure of the root surface by an apical shift in the position of the gingiva. Here with respect to 3-1 and 4-1, we can see gingival recession. Etiology. Plaque-induced gingival inflammation, faulty tooth brushing, anatomic factors, habits, iatrogenic factors, physiologic factors, gingival index given by Louis and Silnes. To the gingival index was given to assess the severity of gingivitis based on color, consistency, and bleeding on probing. Instruments used are mouth mirror probe. The whole mouth is being examined, but the selected teeth are 16, 12, 24, 36, 32, 44. So, surface examined are mesofacial papilla, midfacial, distofacial, and lingual margin. Now, scoring criteria is 0, that means absence of inflammation, 1, mild inflammation, slight change in color, slight edema, but no bleeding on protein present. 2, moderate inflammation, glazing, redness, edema, and hypertrophy, BOP, that is bleeding on protein present. 3, severe inflammation, marked redness, hypertrophy, ulceration, tendency to bleed spontaneously. Now, these images describe the above criteria. Calculations. Gingival index of each teeth is calculated by total score of each tooth divided by 4. Now the total gingival index will be calculated by total of gingival index of each teeth divided by number of teeth examined. So interpretation will be, if the total comes between 0.1 to 1.0, then it is categorized in mild gingivitis. If it comes between 1.1 to 2, then it is moderate gingivitis. And if it comes between 2.1 to 3, then it is characterized as severe gingivitis. Now, periodontal findings. Periodontal findings include periodontal pocket, gingival recession, mobility, furcation involvement. So, periodontal pocket. What is periodontal pocket? It is the pathologic deepening of the gingival sulcus. Normal clinical sulcus depth is 2 to 3 mm. Measurement of periodontal pocket. The only accurate method of detecting and measuring periodontal pocket is careful exploration with a periodontal probe. Radiographs does not reveal pocket. I repeat, radiographs does not reveal pockets. Gutta-percha points or calibrated silver points can be used with the radiographs to assist in determining the level of attachment of periodontal pockets. So, clinical features or sign and symptoms of the periodontal pocket are bluish red marginal gingiva, bluish red vertical zone extending from marginal gingiva to mucogingival junction, rolled marginal gingiva, bleeding, suppuration, that is the pus discharge, extruded tooth. These are some of the basic sign and symptoms of periodontal pocket. So this images show the how to measure the periodontal pocket. Vertical insertion of the probe may not detect interdental craters. Oblique position of the probe reaches the depth of the crater. Walking the probe to explore the entire pocket is the most effective way to measure the depth of the pocket. Now there are two techniques, 4-point technique, 6-point technique. So mostly 6-point technique is used, which includes distally, distofacially, facially, mesiofacially, mesially, mesiolingually, lingually, and distolingually. Pocket depth. is the distance between the base of the pocket to the gingival margin. Now, there are two terms, clinical attachment level and clinical attachment loss. What is clinical attachment loss? It is the root surface which is devoid of PDL, that is periodontal ligament. Now, how to differentiate CAL PPD? PPD is pocket probing depth. As we can see in figure A, gingival margin is above the CEJ, that is cemento-enamel junction. So, CAL, that is clinical attachment level, is PPD, that is pocket probing depth, minus the distance between gingival margin to CEJ. While in figure B, it shows the gingival margin is at the level of CEJ. When in such conditions, pocket probing depth is equals to CAL. That is, pocket probing depth is equals to clinical attachment loss. In the third pitch figure, that is C, as we can see, the gingival margin is below the CEJ, that is cemento-enamel junction. So, pocket probing depth plus the distance between the CEJ to gingival margin is equals to CAL. Is that clear? Gingival recession, apical migration of the marginal gingiva away from the CEJ along the root surface. Here we can very nicely see the picture depicting gingival recession. Etiology, anatomical factors like thin alveolar bone, trauma by toothbrush or nail biting, aberrant frenum attachment. Trauma is like the continuous trauma, everyday trauma. Physiologic factors like orthodontic treatment, pathological factors like local irritants, plaque and calculus, operative procedures, etc. Miller's classification. So Miller's classification for gingival recession. Class 1, marginal tissue recession not extending beyond the mucogingival junction. There is no loss of bone or soft tissue in the interdental area. Class 2, marginal tissue recession extends to or beyond the mucogingival junction. There is no loss of bone or soft tissue loss in the interdental area. Class 3, marginal tissue recession extends beyond the mucogingival junction. There is bone and soft tissue loss interdentally or malpositioning of the tooth. Class 4, marginal tissue recession extends beyond the mucogingival junction. There is severe loss of bone and soft tissue loss interdentally or severe tooth malpositioning. All the four pictures depicts the Miller's classification of gingival recession. Sullivan and Atkins have also given the classification based on the width and how shallow the pocket is. So it is the narrow, shallow, wide, deep, narrow, deep, wide. Mobility. Physiological movement is that which occurs during normal function, that is by 100 to 150 grams. Physiological mobility is defined as movement up to 0.2 mm horizontally and 0.02 axially. The degree of looseness of the tooth beyond physiological movement is pathologic tooth mobility. So both this physiological tooth mobility and pathological tooth mobility, both of them are different. Pathologic tooth mobility is the degree of looseness of the tooth beyond physiological movement. Causes for mobility. Loss of support, that is bone loss. TFO, trauma for occlusion. Spread of inflammation from gingiva to periapex or from pulp to periapex. Pregnancy. Hormonal contraceptives. Cyst. tumors. Now, this picture shows the correct way how to measure the mobility of the tooth. And one side of the tooth, index finger is placed on one side of the tooth, and on the other side, the other end, the blunt end of the probe is placed, and the pressure is applied from both the sides. This is the correct way to measure the mobility of the tooth. Now, Miller's Tooth Mobility Index. Grade 1, Grade 2, Grade 3. Grade 1, slide up to 1 mm. Grade 2, moderate up to 1 to 2 mm of mobility. Grade 3, advanced over 2 mm of mobility, and tooth may also be depressible. Furcation involvement. What is furcation? The anatomic area of multi-rooted tooth where the root diverges. What is furcation involvement? Invasion of the periodontal disease process into the furcation area with resorption of bone. I repeat, invasion of the periodontal disease process into the furcation area with resorption of bone. Etiology of furcation involvement. Anatomic variations like enamel pearls, cervical enamel projections, pathologic, endodontic, iatrogenic. Furcation assessment. Furcation assessment is mainly done by neighbor's probe and radiographs. Furcation involvement can easily be detected by radiographs. Now, Glickman's classification for furcation involvement. Grade 1, incipient or early lesion. The pocket is suprabony, slight bone loss in furcation, no radiographic changes. The images below shows the grade 1 furcation involvement. Grade 2, bone is destroyed on one or more aspects of the furcation, permitting partial penetration of neighbor's probe. This is called cul-de-sac. It is very important. Grade 2 furcation involvement is called cul-de-sac. Radiograph may or may not reveal grade 2 involvement. The below pictures shows grade 2 furcation involvement. Grade 3, interradicular bone is completely lost, but the facial or the lingual surfaces are covered by the gingiva through and through tunnel, radiolucent area between the roots. This is the feature of radiographic finding. So we can see both the images shows grade 3 furcation involvement. Grade 4, interradicular bone is completely lost. The gingival tissues recede apically so that the furcation is seen clinically. So if the furcation is visible by our naked eyes, then it is categorized in grade 4 furcation involvement. Now, what is pathological migration? It refers to the tooth displacement that results when the balance among the forces holding the teeth in position is altered by periodontal disease. Etiology can be abnormal forces, tongue thrusting habits, premature tooth contacts, aggressive periodontitis, or loss of tooth. Here we can easily see the pathologic migrations of teeth. Now, mucogingival problems. Adequacy of attached gingiva. Distance between the mucogingival junction to the external protuberance of the base of the periodontal pocket or the gingival sulcus. Attached gingiva is around 3.5 mm to 4.5 mm in maxillary anteriors, 3.3 mm to 3.9 mm in mandibular anteriors, 1.9 mm in maxillary premolar area, and 1.8 mm in mandibular area. Clinical importance. What is the clinical importance of the attached gingiva? Is that the attached gingiva is firmly adherent to the underlying periosteum and takes the forces of mastication, preventing damage to the underlying blood vessels and nerves. Also, it protects the underlying vital structures from various other insults like physical trauma or anything. Now, test for assessing width of attached gingiva. Direct measurement, indirect measurement, pull test, roll test. Frenal attachments. Frenal attachment can be of four types: mucosal, gingival, papillary, penetrating. Tension test. To know the adequacy of attached gingiva or frenal attachment. Test is positive if the marginal gingiva moves on retracting the lips upward and forward and vice versa. If the marginal gingiva does not move, the test is said to be negative. Fremitus test. Palpable or visible movements of the tooth when subjected to occlusal forces. Class 1, Class 2, Class 3. Class 1 is mild vibration detected. Class 2 is easily palpable vibration. Class 3, visible movements. It is mostly depicted by plus sign. Now, wasting diseases of teeth. Any gradual loss of tooth structure characterized by formation of smooth, polished surfaces without regard to the possible mechanism of this loss. So, now wasting diseases can be either atresia, erosion, abrasion, abfraction. And all of these differ from each other. Please note, atresia is an occlusal or incisal wear resulting from the functional contacts with the opposing teeth. This is very commonly seen in clinical practice. Erosion is loss of non-occluding surfaces present in the form of sharp defined wedge-shaped depression in the cervical area of the facial tooth surface. It can be seen in conditions like eating disorders like anorexia nervosa, bulimia, reflux or chronic regurgitation, regular intake of acidic medication, high consumption of food, acidic drinks or food, professional wine tasting, acid battery workers. Abrasion. Abrasion is the loss of tooth structure due to mechanical wear. Abrasion can be caused by hard bristled toothbrush, coarse abrasive tooth powder, faulty toothbrush technique, action of RPD clasp. Abfraction is the flexure of tooth under heavy lateral load which may lead to fracture of enamel rods at cemento-enamel junction. Plunger cusps. Plunger cusps are the cusps that forcefully wedge the food into interproximal embrasure of opposing teeth. So here we can easily see the plunger cusp has been pushing forcefully wedging the food into the open contact area on the opposing teeth. Food impaction is the forceful wedging of food into periodontium by occlusal forces. Hirschfeld in 1930 classified vertical food impaction. Class 1 occlusal wear, Class 2 loss of proximal support, Class 3 extrusion of tooth, Class 4 congenital morphological abnormalities, Class 5 improper restorations. investigations, full math IPA or OPG, complete hemogram. Now, provisional diagnosis. Based on this clinical examination, we would reach on the conclusion of provisional diagnosis and prognosis. Prognosis can be of the individual tooth or overall prognosis. It can be either excellent, good, fair, or poor. Treatment plan. So treatment plan includes preliminary phase, phase 1 therapy, that is etiologic phase, phase 2 therapy, surgical phase 3 therapy, restorative phase 4 therapy, maintenance phase. So here my presentation ends. Thank you so much.